but since I gave it I would. And I think the catch is that there's just so much going on in diabetes now that I could easily have talked for about 2 hours. Just a bit worried that I might have rushed the audience through it.
So what do you think were some of the key themes? You said there's a lot going on. What was kind of key themes?
Key thing number one is spotting and avoiding hypos. So we have a real problem. Everyone's having their blood sugar driven down, and then they get older, lose weight, worse renal function, eating less, and then they go hypo. People are still not picking it up. It's a real concern. The second thing we're seeing is the new agents. The new agents are really amazing. But for instance, if you have someone on once-day long-acting insulin and they're failing and you want to add in something else, adding in insulin spark would be cheap, adding in liraglutide gives much better results, this much more expensive. And similarly with gliptins, I really think the data is coming out now, looking at the safety and the mortality data of SUs, which seems to be a very consistent thing from UKG database. It would suggest that SUs aren't particularly safe, but they're cheap, whereas a gliptin is a lot more expensive. I think it's quite difficult, but if it was my mother, who isn't actually diabetic, but if she was, after metformin, I'd probably be going for a gliptin rather than an SU.
Given that it's also World Mental Health Day today, I was quite interested by the link you highlighted between hypo and dementia. Could you tell us a bit about that?
Yeah, that's a real concern, and we don't know the mechanism, but certainly the Witness study was controlled for as many variables as they could, and it seems to be sort of validated by Scottish and other North American data. So if people in late middle age have some significant hypos, and some hypos needing admission to hospital, it increases the risk of dementia later on.
There's a broad range of other talks going on today. Could you tell us what some of your key takeaways from those were?
Yeah, I really enjoyed the new anticoagulants in AF. I hadn't realised how common AF was as a risk factor for ending up on the stroke unit, and really the adverse outcomes, the increased duration of stay, the increased mortality of strokes associated with AF. And the other really key point for that talk was actually worry about patients bleeding, but the patients that are likely to bleed are also the ones who are likely to have further strokes. So really, we should be thinning more people's blood, and the new anticoagulants, they do seem more consistent. So, if warfarin a third of the time you're not to target INR, with new anticoagulants you're to target, you thin the blood appropriately all the time. So that was really valuable. The continence talk by Susie Orr, that was fantastic. And really lots of the speakers, they've just been really good advocates for their field. And emphasising that with the older person with incontinence, it's just part of a set of problems they have, and we should be addressing them as part of that comprehensive geriatric assessment. That was a really good talk. And actually Mike Stone's talk just now on osteoporosis and looking at the value of things like intravenous bisphosphonates, the new denosumab agents, so much more going on. And really the finding that as people get older, bisphosphonates less valuable, and denosumab might be more valuable. So yeah, key messages there.
So given the range of topics, but also the interrelations, you both yourself and Michael touched on vitamin D within your talk, for example.
Yeah.
Do you think an integrated health and social care approach for dealing with the older generation, how important is that, do you believe?
Yeah, I strongly believe in links, and it's really important they work together. So I work very closely with my social workers, with the social services departments, and with general practitioners. And this is one of the things that really bugs me, is that, for instance, if GPs email me, I can send them a response, possibly, say for a clinic visit, but by doing that, then my trust doesn't get the money for the clinic visit. So in terms of looking after the older person, we're really keen on building up the links with different departments. So hospital care, linking with primary care, medical staff, nursing staff, linking with social services, but also linking with the care homes. And so we're linked very closely by reason of the work we do with care homes, which have strong links there as well.
So finally, how useful do you feel it is for an event like this with practitioners from a number of backgrounds being able to get together and work?
I think it's really valuable because I do my work and I concentrate on the older diabetic person, and so knowing what's going on in the other fields is really useful. And the talks here, they're just really practical from people that know what they're doing. They are really keen and enthusiastic on it, and it's just very, very practical. I'll go off and get the juniors to audit catheters in our hospital, and I'll change my practice and be more proactive and aggressive about thinning people's blood.